A distinct privilege and pleasure this morning to have the opportunity to listen to Professor Andrea Gershon speak to us about improving quality of care in COPD. Andrea has been a long-term colleague and friend, has trained in Toronto, has worked in Toronto for about 20 years or so now, has graduated through the ranks of lecturer, assistant, associate, and full professor in the Department of Medicine. Andrea's research interests have been largely in the area of airway diseases and in the epidemiology of these, and in using larger banks of information to help inform us about details about our patients and about their care. She's been a senior core scientist and the Institute for Clinical Evaluative Sciences, that's ISIS, for quite a number of years. And this has been a powerful association for her, and has led to her being extremely productive. It's humbling to read her CV. It's quite long, and in fact, it's a small book at this stage. She's contributed mightily in print, but also in person at meetings and in committees, and with the Ministry of Health and other institutions that try to help organize how we deliver best care to our patients. So, Andrea, it's indeed a pleasure to welcome you back to McMaster, to St. Joseph's Hospital. You've been here before. It's nice to see you again.
Thank you. Shall I just stand here and advance the slides?
Because the microphone presumes.
Got it. Right, got it. Okay. So thank you for the very kind introduction, and thank you for the invitation to talk. I always love talking about my work. Today I'm going to talk about improving quality of COPD care and tell you about my research program. Sorry. Oh, first the learning objectives. So, and during this presentation, I hope that you will learn about how quality of care, COPD care is measured. We'll list some barriers to optimal COPD quality care and consider how the knowledge to action cycle can be used to improve care with people with COPD. And I'm also going to use this opportunity to shamelessly promote my research program, which we have named CanBREATHE. We call ourselves the Canadian's Best Respiratory Research Evaluation Analyst Team of Health Experts. And some of you are already part of this. And this is our website. And for those who showed up in person, I'm very grateful because I'm just loving in person. And I have some, again, in shameless promotion, I brought some highlighters, some CanBREATHE highlighters. So please help yourself. There's just a few of them on your way out. But I'm here to talk about COPD and why COPD. I know I don't have to explain to this audience, but COPD affects more than 300 million people. There's been a 5.9% increase in the prevalence of COPD between 1990 and 2017. It disproportionately affects marginalized populations, and so it's a global health crisis. And I'm going to go on telling you a little bit more before I get into the actual quality of care. I'm going to talk a little bit more about the epidemiology of COPD, because this is part of my research program and what I've done. So a long time ago, we described the prevalence trends in COPD. We found that 11.8% of the Ontario population was affected, the Ontario adult population was affected by COPD in 2014-15, and that the rates were going up. They were going up higher in women as opposed to men. And as you can see, this graph is a little bit old. This is from our publication in 2010, a little bit old, but we've actually followed this out and done forecasts. And again, now this is a little bit old, but it seems like we're all in the growth industry, and COPD will continue to increase. We also studied the lifetime risk of developing COPD. And in this situation, we looked at the risk of somebody being diagnosed with COPD up to age 80. Just making sure that the mouse is working. And you can see that there's a 25% chance of all of us being diagnosed with COPD during our lifetime, which just falls a little bit short of asthma and diabetes in men and also in women, but is higher than prostate cancer and congestive heart failure in men, and breast cancer and congestive heart failure in women. And you say, why are you comparing COPD to cancer? It's really high mortality. It's different type of disease, but really we have very high mortality. I'm going to show you that too. Of course, the prevalence of COPD is only part of only part of the picture, because we know that COPD is terribly underdiagnosed. This isn't my data, but shows the rates of underdiagnosis of COPD around the world. And of course, we found this in Ontario, and this is CanCold data. If you're not familiar with CanCold data, I'm happy to talk about it afterwards with anyone. But when they did random digit dialing and got members of the general population to come in to do pulmonary function tests, they found that, you know, of all the people who were found to have COPD, 73% of people in Vancouver didn't know that they hadn't been diagnosed with COPD before, and similar rates in other Canadian cities. So probably the prevalence is much bigger than we believe it is. And of course, mortality of COPD is very high as well. This is again old data. Haven't seen this. I think there is an updated version of this, but not too updated. COPD named the third leading cause of mortality worldwide. That's still the case today. And so the COPD challenge, as I've always seen it, is that the connection to tobacco has always been a major impediment. And there's often this unspoken belief that COPD sufferers are authors of their own misfortune, even by people with COPD themselves. COPD also doesn't have a high profile, arguably has a terrible name. It's forgotten, overlooked. And the result is an illness that places a tremendous burden on not only the healthcare system, but on individuals and their families. But I also see this as an opportunity, because really, I think things have changed in the last several years and we're getting better, but still there's so many simple things I believe that we can do that can have a great effect and help people with COPD. I don't think this is a good thing. I just think it's just because there's so little out there for people with COPD when you compare it to people with heart disease and cancer, for example. And so, but how do you get these things done? And so I wanted to bring this back to the knowledge action cycle. And I use this to guide a lot of my work over the years. And so if you're not, this is a very good cycle to know. And I'm sure most of you do know it, but if you haven't, I'll just walk you through a little bit of it. So this is like, how do you affect change? How do you improve quality of care? And so you start down here at the bottom, where you really identify what the problem is. And once you know what the problem is, you can go ahead and start assessing the knowledge about it, assess barriers to it, and then you can start tailoring interventions to try and solve this problem. You can't solve the problem if you don't know what it is, so that's why you start down here. Once you've implemented this intervention, you don't stop there. I think sometimes some organizations think that this is great. We've solved the problem. We have it there, but that's not where you stop. You continue to monitor use and evaluate outcomes. And of course, when you evaluate the outcomes, you know that your implementation is probably not perfect. You probably have found new problems that are going on. So the cycle comes around again, where you identify another problem, and then you get to go around again and again and again, and improve care, and improve it, which is always a good feeling. So in the middle here, we have knowledge creation. I'm not going to go into this, but this has to do with, synthesizing knowledge. So you're not just using like one small study, you're actually using the body of knowledge that we have critically. So when I started my journey on this, and maybe I'll just say as an aside, I was trying to think of what to present today and what I could do. I thought I could present some of my COVID work, or like preliminary, our multi-site national long COVID study. We're doing some work in remote monitoring. I chose to to go with something that was pretty established and safe, to give you an idea of some of the work that I do and some of the work that where it comes from. I think I also, well, the reason why I mostly chose this is because this is like the most complete work I've done. And it's one where you can kind of start at the beginning and see how things progressed over time. And I thought that that would be kind of fun to present to you and get some feedback on. So starting back at that knowledge to action cycle, the first thing is identify the problem. So the question is, what is the current quality of COPD care? And the answer is, we don't know. The answer, when I started this was, we don't know. I'd argue it's still, we don't know, because we don't have a really good sense of what's going on, especially now after COVID and everything's been kind of upturned and we're wondering what's going on with our patients. But especially then, we did not know. So how do you identify the problem? Yeah, you got to measure it. I mean, I have my biases, but I think everyone will agree. If you can't measure it, you really can't manage it. I don't know who originally said this. It's commonly, I like to cite the person who originally said it, but it's all over the internet and people quote it all the time. So measures, of course, allow physicians, hospital, healthcare organizations to identify and prioritize gaps and then design strategies to address them. So when we looked around, several years ago, not that long ago, but several years ago, we wanted to measure it and we didn't find really much to measure it with. So we set out in order to measure, we decided we had to develop COPD quality indicators. And this is one of our first papers, developing COPD quality indicators using a modified RAND appropriateness method. Now, again, I'm sure many people are familiar with that, but just for those who aren't, quality indicators are measures associated with such a strong benefit that failure to address them reduces the likelihood of good outcomes. They can be the outcomes of clinical care, like, how many hospitalizations have we had in an area? How many people are going to the emergency department? Because obviously those are lower, that probably means we're doing better. They can be, although not always, they could be processes of care, like important clinical actions. And I'm going to talk a lot about pulmonary function testing to diagnose COPD, but it could be like a medication that you give or pulmonary rehab, for example. Or it could be structures of care. It could be facilities, equipment, how many qualified personnel, how many respirologists you have, how many respiratory therapists you have, or it could be organizational structures. So we set out to measure this and determine what these were. And we started off, I talked about this modified RAND appropriateness method. It sounds really fancy, but what it really just means is that first you do a systematic review of the evidence, and then you get a Delphi panel to interpret the results. So we did a systematic review looking at existing COPD quality indicators. There are a few out there. We did systematic reviews. We looked at individual studies and we synthesized them into our own systematic reviews. And then we put that together to a Delphi expert panel to interpret and contextualize the results to Ontario, which was the context of where we wanted these quality indicators to be used. What does a Delphi mean? If you're not familiar, like when you get together as a group and you're going to solve a problem and there's one person who's really loud and they talk all the time. I mean, you got I love those people because then I'm the other one that's quiet and I don't have to talk all the time, but it doesn't really get everybody's opinions, right? So the Delphi, you have basically anonymous voting. You do have face-to-face meetings, but you can do it different ways, but you do have periods of time where everybody goes back to their corners and they vote and they give their opinions, and then they can come back. So it makes it so everybody's voice is heard. And this is important because there's a lot of people who need to be heard when you're talking about COPD. And we made sure that we had a multidisciplinary panel of healthcare providers, governments, state, lung association, everything. We did not have a patient We did not have a patient. We had patient representatives. That was a huge oversight, but it wasn't as, wasn't as popular at that time. So what we ended up with is the final list of COPD quality indicators, 33 of them. We actually ended up with many more, but this is what the panel felt was important. And we kind of broke them down into these categories of screening, diagnosis, smoking cessation. But anyway, I don't have the whole list of the 33 here, but hopefully you can get an idea, and I'm happy to provide you with a copy of this. And, right off the bat, these quality indicators were a hit. Health Quality Ontario, which I know is very old at this point in time, thought these are great. I'll talk a little bit about the Ontario health teams, which have also adopted quality indicators, but they were ready to use these. And we were too. We wanted to jump right in and find out what the quality of COPD care and what we could do. So we started with, we thought was a pretty straightforward one, a pretty fundamental one, which was spirometry to confirm the diagnosis. So the quality indicator, this measure of quality was measure of a percentage. And the percentage was percentage of people with a clinical diagnosis of COPD who actually had received pulmonary function tests. So that brought us to our pulmonary function lab. Our lab doesn't look like this anymore because it's cornered off because of COVID and things have changed. But the question, one of the first questions we asked was, how often are pulmonary function tests being used to diagnose COPD? And this led to this publication. And not only do we want to determine the proportion of people diagnosed with COPD, we want to determine factors associated with not receiving pulmonary function tests. I'll just pause there for a second, because have people read the Lancet COPD, Commission on COPD? Yes. Yeah. So very interesting publication. I'm still making my way through it. It's like 40 pages long, but I encourage you to read it. And like one of the things they're saying is like, hey, maybe we shouldn't be using pulmonary function tests to diagnose COPD anymore. They don't capture everybody. CT scans are much more common in many countries than pulmonary function tests. Anyway, just putting that out there, I think that that's a very interesting conversation, and don't mean to negate that, and I'm very interested in that, but I still think pulmonary function tests play a fundamental role, and of course they did when we did this study. So we did a study, a retrospective cohort study using health administrative data, and it was set in Ontario, Canada between 2000 and 2010. And we looked at all individuals 35 and older who had a new physician diagnosis of COPD. And so I'm not sure if you're familiar, so ICES, of which there's a McMaster ICES, has access to a lot of health administrative data, also other data sets too. There's a registered person data set that gives demographic information. There's a data set with physician billing records. There's a hospital discharge record data set, emergency department visits. As you know, we have prescription drugs that are provided by the ODB for people age 65 and older. And you can also get additional information if you want from the Canadian Community Health Survey. The Canadian Community Health Survey is a population-based survey that's done, I guess, actually every year now, like a random sample of the population, and it asks more in-depth information about people's health. And also their financial situation, other things. Anyway, we find that very key in our study because it has information on smoking. And although we don't have smoking for the whole population, we do have a smoking for a population-based sample, which we can then extrapolate to the whole population. We've been very successful for doing that in the past. And if you're wondering about a colleague of mine, Peter Austin just recently published a paper saying that, this is fine. This actually works really well. He's validated this methods. But anyway, as you can say, I like going off little slides, but all these data sources, all these databases are linked together on an individual level. So you can see if somebody went to hospital on Thursday, got discharged on a Sunday, saw their family doctor on a Monday, and then filled a prescription on a Tuesday. So you can imagine it's not a lot of information about people in the database, but like 14 million people, like it's a crazy amount of people, right? So it's very exciting data to work with. And so we use this data, and the outcome of our study was receipt of pulmonary function testing in the peri-diagnostic period, so around when the diagnosis of COPD was made. And that's why we're going to be very generous about this. We want to give people the benefit of the doubt. So we decided that we'll look from 1 year prior to 1 year following the date of diagnosis. And we decided we'll just like maybe that doctor or that healthcare provider didn't know what they were doing. If they send them for any type of pulmonary function test, we'll take it. Well, not any type, but we'll take flow volume loops, we'll take diffusion capacity, because it kind of gives you an idea if somebody has COPD. We'll take like a methylcholine challenge just so you get the flow volume. Anyway, we'll take anything. And that was our outcome. And then, so for the biostatisticians in the audience, we did a complete case analysis using generalized estimated equation models, examined the association between pulmonary function testing and the predictors. We adjusted for patient clustering within primary care physician or within physician because there might be variation there. And we were looking at the prevalence ratios, which is the ratio of two prevalences if you did or you didn't get pulmonary function tests. Sorry, if you did or did not have a characteristic, the prevalence of COPD and those had a given characteristics to those without. And these are our results. So over 500,000 Ontarians were newly diagnosed with COPD during the study period. Just a little more than 1/3 received pulmonary function testing, like in that peri-diagnostic period. We knew it was going to be low. We didn't know it was going to be that low. And then these are some of the characteristics that were associated with not getting pulmonary function testing. So younger people, and I'm sorry for that so small. But again, I'm happy to provide copies of any of these if people are interested. So younger people and older people were less likely to get pulmonary function testing. If you're a female, slightly less likely. If you're in long-term care, you weren't less likely. If you had comorbidities such as stroke and dementia, you're less likely. If you had a respirologist, a specialist involved in your care, you were more likely to get pulmonary function testing. If you had other respiratory diseases, more likely to get pulmonary function testing. And interestingly, if you had an older physician age was associated with pulmonary function tests. So if your physician was over age 65, you were less likely to get pulmonary function testing. So this kind of just, so younger and older, this summarizes what I just said. Interestingly, the people who had a specialist involved in their care, the rate among respirologists was still only about like 80%, 79.1%. So I think that kind of speaks to like not everybody can go for pulmonary. Like we know there's contraindications. Maybe respirologists could do better. But like there is, when you look at these percentages for quality indicator, the aim isn't 100% necessarily. So you have to kind of find out where that benchmark is. That's reasonable, that takes into account contraindications and such. I'll just say up front, we don't know where the benchmarks are for these COPD indicators, but doing studies like this help us try and figure out what that is. And arguably 79 or 80% is maybe a benchmark that we should be reaching for. So that 80% of all our patients have pulmonary function tests. But a big message from the study was that most COPD in Ontario was diagnosed by clinical evaluation without objective pulmonary function testing. And this obviously points to a huge gap, like the Lancet Commission aside, points to a huge gap in the quality of COPD diagnosis, which undermines all subsequent care for people with COPD and increases the chance of missing other important diagnoses. And just if you're wondering, why, like because we were very over generous with what we accepted as being pulmonary function testing, we actually also looked at post-bronchodilator spirometry to confirm diagnosis. And we found that it would, as you would expect, it's even lower, like around 20–25%. In more recent studies, this number has come up. I think I've seen as high as 40%. But there's still a lot, more recent years, as high as 40%. We haven't looked over COVID. Actually, we don't want to look over COVID. I'm sure it's going to be very, very low. But I don't think we've jumped from 30% to 80% in the last few years. So this continues to be a big problem. Any questions? Maybe I'll just pause there because any questions or?
Andrea,
Yeah.
that's why I call it CanBREATHE is to say that COPD is chronic overdiagnosed pulmonary disease.
Yeah.
So, there was under and over, we need to develop outcomes from testing COPD, whatever the commission says
Yeah. I kind of excited by the new ideas that they're introducing, but yeah, we need to have, I think it's a long time to start with that question. But thank you for bringing it up. We have used scalable data, we linked it to the health and data, we have looked at overdiagnosis and underdiagnosis. Underdiagnosis is a much bigger problem. But you're very observant in the sense that pulmonary function has really helped you with overdiagnosis. I mean, if you're not getting presumed that CFP low is low in people who have COPD, and it's probably low in people who think might have COPD, so that will contribute to underdiagnosis. But
spirometry also has a disadvantage in the UK, for example, when we think so, we much more spirometry than in Canada, where they've got an incentive to do it because they get paid. If you're doing just for getting paid, with very poor emphasis on quality of spirometry. So they buy these multiple spirometers, no quality control to do a spirometry, even then, because the data is
sorry, I forgot I'm supposed to stand here. Yeah. No, I didn't realize I didn't identify the problem, but you point out a really good point, which I didn't really talk about as in the limitations, is that we don't know the quality of a spirometry. We just know that it's being done. So.
One question that I deal with, since a lot of centers in Ontario are moving towards epic-based EMR, is that the quality of the data that's being inputted as to whether someone has a diagnosis, I believe is becoming even more variable. So as people are entering this into the database, it's like you're having, and I don't mean to be prejudiced against them, but say a junior member of the team, someone comes in, they're a smoker and they're short of breath, you get labeled as COPD and it carries with them the chart for the rest of the time. That data subsequently gets incorporated into the ICS database. And then they come to me in the pulmonary hypertension clinic or something, and they're like, "Oh, it's group 3 pulmonary hypertension related to COPD." I'm like, "They never even have COPD." And so it's, I wonder whether or not this problem is going to be amplified as we move more and more towards these very useful instruments, but sometimes can be crude in terms of the way that we track data over time.
That's very interesting, and I'm smiling underneath my mask because, of course. Actually, am I allowed to take my off my mask if I'm more than 2 meters away from people? Okay. I'm smiling underneath my mask because yeah, I've been like in the EMR, it's just like people just cut and paste like big huge chunks, and it's like word for word, and it's like, yeah, this is amplified 10 times, but is it right? Yeah, I hear what you're saying, and that's why obviously I'm not able to touch on everything, but that's why you really have to validate these quality indicators, and probably we're due for an update and a validation of our quality indicators. The only other thing that kind of interests me is that, we have so many more tools, like we have EMRs now, so hopefully that those deficiencies are going to be counteracted by more efficiencies. Like, for example, more people getting pulmonary function tests, and hey, it's in the EMR, so you can actually find them, right? Like, so maybe that will hopefully make a difference. But
fingers crossed.
Yeah, but I appreciate you pointing that out because I think it's very important. So, so our next question, of course, was, you get this bird's eye view of what's going on, but why are pulmonary function tests not being used? And so, I mean, I'm not a survey researcher, I'm a qualitative researcher, although I'm going to talk about some collaborations later on that I'm doing. But we looked at the literature, and there have been surveys of physicians. And there's a couple of messages that come out very loud and clear. And I've heard these messages recently, right? Like, these are not old messages. And that's that, we can diagnose COPD without pulmonary function tests. And there's no evidence that using pulmonary function tests actually improves health outcomes. I don't mean to come down hard on my primary care colleagues, but I mean, these aren't the arguments that you'll hear in rounds like this, but you might hear out in the community. And they probably have, experience that shows that this is true. But we heard these messages, and you don't usually hold a diagnostic test to that highest standard that you have to show that like an EKG improves outcomes and like reduces heart attacks. But we took on the challenge. We thought, okay, people are saying there's no evidence, we're going to create the evidence. So that led to this study, outcomes of patients with COPD diagnosed with and without pulmonary function testing. And so we hypothesized that individuals with COPD have had their diagnosis confirmed with objective PFTs had better health than those who did not. So again, we did an observational longitudinal population-based cohort study using our health admin data. We used the same databases that I described before. And this time we kind of narrowed down the use of pulmonary function testing to like things that we thought would actually be helpful and be able to influence outcomes. So this is just, sorry, I may have gone over this a little quickly before, but these are actually the OHIP codes for COPD, for pulmonary function testing that we use. And our outcome was a composite of COPD hospitalizations and all-cause mortality. And that's just because hospitalizations are on the causal pathway to all-cause mortality. So you kind of have to look at them both. And then in terms of variables, so we're looking at people who did and did not get pulmonary function testing. We looked at many, many different variables in these groups: demographic variables, COPD variables, general health, primary care visits, influenza vaccinations, anything that we thought that could influence the outcomes and be associated with pulmonary function tests in some way or another. Comorbidity, recent acute events. We looked at primary care physician characteristics because before we showed that older primary care physicians were less likely to order pulmonary function tests. And we also looked at other quality of care measures, like glucose and cholesterol testing, because if somebody who was more likely to measure pulmonary function tests just gets better overall care, then of course their patients are going to do better. So we did that. We addressed that in a couple of ways, and that was one way. So this is just the setup of our exam. So we have the index date. So people with pulmonary function tests or no pulmonary function tests, they entered the study. And then so people with pulmonary function tests were matched to people without pulmonary function tests on the day of the pulmonary function test. We followed them forward in time to whether they had a COPD hospitalization or death. And so what we chose to do was a propensity score adjusted analysis. That models the probability of the person received pulmonary function tests using the list of potential confounders. And then we use logistic regression and all the covariables, which allowed us to observe people in the pulmonary function test group and people in the non-pulmonary function test group who had similar characteristics. Sorry, Aaron.
No, major problem that I'm not familiar with is when you do this linkage-based analysis.
Yeah.
It was massive from the research.
Yes.
It's how do you account for medication use when Ontario assumes that a universal drug plan and your data will be limited to only those who are covered by government funds?
Yes. Yes.
How do you account for medication use in the two groups?
Well, I will show you. I will show you because we have to be creative because we don't have all that information. So give me another slide. We looked at outcomes in patients who did and did not receive pulmonary function tests using a Cox proportional hazard regression analysis. And we used pulmonary function tests in the follow-up period. We looked at that as a time varying covariate. Went out, didn't see that. And then so this is what we did. We used propensity score matching, and then we did propensity score calibration. And I won't go into the details of this, but that allowed us to get certain variables, smoking status and exposure. So secondary smoking exposure, secondary smoke exposure, BMI, from the Canadian Community Health Survey, and include that in our propensity scores, and able to kind of roll that up to extrapolate to the whole population. So we're able to account for smoking. We're still not able to account for medications because we only have that for those people age 65 and older. So we actually did a sensitivity analysis in individuals age 67. I can't remember why we use 67 now. I have to refresh my memory, and not 66, because you need the 1 year look back, so you can't start at age 65. I think we did it to be consistent with some of the other quality indicators that we're measuring at the time. We looked at analysis in people age 67 year and older who had medication, and that allowed us to exclude patients who were taking medication prior to the diagnosis in the health admin data. So maybe they had been diagnosed before, or the doctor was thinking about it in their head and started the medication before it shows up in the health admin data. It also allowed adjustment for prior medication use. And it also allowed comparison of medication use before and after the diagnosis in both groups. So not ideal, but we were able to address that limitation. And then we also, of course, use methods that we always use to determine the plausibility that unmeasured confounding or misclassification of the COPD diagnosis accounted for the results. And these are the results. So we had about almost 70,000 individuals with physician diagnosed COPD. Of 41.2% received pulmonary function tests. So already you're seeing things are looking up. This is a later study. And when we looked at the results, we look at death or hospitalization for COPD, it was adjusted hazard ratio of 0.91, which was significant, which means that people with COPD who got pulmonary function tests were 9% less likely to have a hospitalization or die, all-cause mortality, in people who did not get pulmonary function tests. And that was pretty consistent for a lot of our outcomes here. What was interesting is there's actually significant interactions by age and by where the COPD was diagnosed. So I'll just talk about the latter one because that was the most, it seemed like the most important one. If COPD was diagnosed from previous ambulatory care visits, then you can see these hazard ratios, which by the way, have 95% confidence intervals around them. They're just so tight because our numbers are so big that you can't see them. But these, this is a forest plot. These hazard ratios are on the side of the beneficial effect of pulmonary function testing, on this side of 1. And if you look at COPD that was diagnosed from a previous hospital admission, so the first time they presented is at a hospital, they get diagnosed with COPD. You can see that, I mean, I don't know why pulmonary function tests would have a detrimental effect, but they're not, they're on the other side of 1. So there doesn't seem to be the benefit there. And then if you look at, sorry, does that make sense? Okay.
No, you could then argue that it's nothing to do with doing your pulmonary function test simply the use of medication, because your medication information is on patients who are older and they're treated. You don't have that information on the younger because you don't have the medication.
Oh, okay. Well, but we did the sensitivity analysis in people who are older, and we found the same results. Like when we did adjust for medication use in older people, we found the same results. With the sensitivity analysis, yes.
But it could be just that people were treated and have the information, but in the younger, they don't have information.
Yes, yes, and we are extrapolating, but I don't know.
I mean, that's a problem with our database if we don't have good medication.
Yeah, and sometimes you have to look at like what's the alternative, because we're not going to do a randomized controlled trial and randomize people to PFTs and not PFTs, right? Maybe. Did anybody here set their patient for that study?
This is a pragmatic analysis, a pragmatic study.
But then you're not necessarily randomizing people. Anyway, I'm very intrigued by that. I think it would be very interesting. I think it would be very challenging.
Doesn't this just sort of speak to baseline severity of disease?
Yes,
Like,
yes.
You think like you have a young person who's admitted to hospital, and the person who was taking care of them felt strongly enough that that person needed a breathing test, making like the idea that their diagnostic confidence that this is someone with really bad lung disease much higher, so they're more likely to go for a breathing test versus the 80-year-old who comes in for, as Dr. Nair so eloquently said, slap therapy. And you're like, well, they may have COPD, but we're not going to, we are or are not, because it's not going to really manage. Like, could that not explain?
I think, I mean, I think so. I mean, my thought was that, you know, once you get a certain, I kind of thought of it a little bit different way. I thought like once you kind of get a certain severity of disease, it's really hard to change the natural course. So you want the pulmonary function test done early, you know what the disease is, and then you can start implementing things that can change things and be preventive. But yeah, lots of interpretations, and it's only observational study. And you know, these types of studies are hypothesis generating, right? I still think it would be a challenge to actually do this study, especially with what it showed. Which anyway, sorry, I'm going to summarize things in just a minute. But here, when we looked at patients aged 67 and older, we found that those who received pulmonary function tests were a lot more likely to get medications than those who did not receive pulmonary function tests. Now, that doesn't say that those medications were necessarily given appropriately in all situations, but it does seem like there is some sort of, it's not the pulmonary function test that's making people better, it's the medication use probably, and maybe other parts of their care. And then these results of the pulmonary, all of the results of our sensitivity analysis, as I said, were consistent with the main results. And we looked at unmeasured confounding and misclassification. We found that, you know, these could account for what the findings that we found in very, very unlikely scenarios. So COPD patients who had their diagnosis confirmed with pulmonary function tests were 9% less likely to die or be hospitalized for COPD, but is significantly influenced by diagnostic setting or probably severity of disease. That's my belief too. And that people who are diagnosed in the ambulatory care setting were 20% less likely to be hospitalized or have all-cause mortality. And so this really validates international guidelines recommending pulmonary function testing for diagnosis. Of course, there's limitations, which some of them have been pointed out. There's a potential for misclassification based on the case definition. Unmeasured confounding could still be an issue. And also, of course, association does not mean causation. And this just basically says, and then just pointing out that given the 36% rate of pulmonary function tests being used, there's a tremendous opportunity to improve health of the COPD population. And this was quickly picked up by Health Quality Ontario in their COPD reviews at the time. And of course, Choosing Wisely also recommends pulmonary function testing for in people with suspected COPD. So I think I'm running out of time, but maybe I'll just kind of show you just quickly some of the other stuff. So this work has been taken up by my colleague Samir Gupta. You know, where I end off, he takes off. So he's actually has methods, more systematic reviews, more qualitative methods, looking at the barriers and enables to objective testing. So he's used this as basis to move on to look at this. I won't look into this. So he found through systematic reviews, he's found a number of barriers and enablers for pulmonary function testing, which we're studying. This is just one of 33 quality indicators that we have used, that we have looked at. And so lots of more potential to use this knowledge to action process to look at other ones. And one of the other ones what we've looked at, and also in a little bit of detail, is end-of-life strategies among patients with advanced COPD. We all know the benefits of a palliative approach to managing COPD, but first, people with COPD are less likely than those with cancer to receive palliative care, despite studies have shown a similar burden of disease, and few population-based studies that ever looked at this. We looked at long-term oxygen use, opioid use, and palliative care, formal palliative care for people with COPD, and found that although rates were kind of getting better over time, they're still quite low. Not surprisingly, I think we all know this intuitively in Ontario. We've also looked at smoking and smoking cessation among people with COPD, which address some of our other quality indicators. We've looked at influenza vaccination effectiveness in preventing hospitalizations in people with COPD. And we've looked at, what physicians, respirologists care in people with COPD as again, just kind of measuring the COPD, the quality of care that people are getting. Our work has also led to other work, looking at developing quality indicator for pulmonary rehab programs in Canada. And most recently, I mean, all this work was kind of sidelined by COVID, but recently the Ontario health teams are very interested in this work, and many have identified COPD as their target condition and are using the quality indicators in a lot of our work, and have a lot of interest in expanding this work to study this more. So overall conclusions, that COPD is a highly prevalent and deadly disease that places a large burden on individuals and healthcare systems. Measuring quality COPD care reveals areas for improvements, and population and health services observational research with big data can provide new knowledge and decision-making support for real and pressing respiratory disease clinical problems. And of course, I don't work alone, so I have a lot of people to thank and funding sources to thank. And thank you very much. Happy to take questions. Yeah.
Hi, Andrea. We did a sort of question people refer to clinic here with diagnosis of COPD. We find that less than 7% of them ever had spinal treatment before. In the old days, when they looked at databases, certainly if I'm wrong, in Canada, we were really very aggressive with anticholinergic management. And it used to be the prescription of anticholinergics when a patient was enough. Someone who is 40 should make a presumed diagnosis and then work back from that, from whether they had spirometry or whether they had whatever.
Yes.
And you sort of changed the way you've done things. And you look at it from that way, quickly down to smoking data as well.
Yes. So the question is, if I have it right, can we use other indicators of COPD to make sure we have people with COPD specific for use anticholinergic use and such? That's very interesting. And so as Param pointed out, we don't have medication use. We only have medication use for people age 65 and older in the health admin data. But I did work with we have been working with our primary care colleagues to look at identifying people with COPD using EMRs, which is very important. Because again, not everybody has spirometry, and anticholinergic use has been that's in our algorithms in that setting, in those situations.
Just when you have big caveats, if you look at people under the age of 40, the reason for that is if they have been fit into your parameters, even though we wouldn't consider that being COPD, if that fit into your parameters, it'd be a nice way to add that sensory analysis. Honestly, they've been theory misdiagnosed.
So you're saying if we look at people under 40,
we fit your criteria. I know you're looking at older people, but it would be a way you could actually then look at why were they classified.
Yes. We give the question. I'm supposed to repeat the question. The question is, because we have medication for older people, but if we want to look at younger people, we start using EMRs, and we can kind of expand the breadth and of information that we have to make those interpretations, and maybe actually even help classify them better.
The last question I have is that we did a survey here where we find that for every echo or every spirometry cardiologist order, we order 400 echoes. So big cardiology databases have been very reluctant to add in spirometry as a outcome measure. And surely the major risk factor for all the cardiac disease is smoking.
Yes.
And if you call it cardiac disease, surely what drives a lot of the problem.
Yes. So you're pointing out that there's much more echoes done than spirometry, and that the large databases, cardiac databases, don't really include spirometry. Yeah, I've really noticed that, because I don't know if you're familiar with CanHeart that Jack 2 started, and they've continued these databases, and I was part of that for a long time, and I was always pushing to get more respiratory data in there, and I was actually studying parts of that. We have a couple studies coming out looking at using the CanHeart databases, which don't have, well, but we put spirometry in them, whether it was done or not, to look at heart disease and COPD. And yeah, I think that that's way overdue, and people have to, I need to get back in touch with them, start nudging them in that direction again. But I think that that's very important. Thank you.
Go ahead, Peter.
Yeah, I'm interacting from the Netherlands. I'm quite sure the number is saying nothing. I was just wondering, you know that such a big database.
But you have some really nice databases there. They've done some really good work.
Are you also able to do whether a diagnosis of COPD sometimes is really wrong? So if you
Yes.
had a COPD diagnosis, that's probably more than a diagnosis. So
Yes. Yeah, so I didn't talk about our validation work as whether people had COPD, like how we identify people with COPD, but we have validated diagnosis of COPD with about 80% sensitivity and 80% specificity to know if somebody has a diagnosis of COPD. We don't have a validated algorithm to find out if they stop having a diagnosis of COPD. And I always thought that that was fair, because when somebody's diagnosed with COPD, it's not like the COPD goes away. I guess unless they get a lung transplant or something. But you're right, though. If we can look at the data and see if like people stop showing up with COPD in the data, then what happens to them? And then maybe we can do an exit strategy as well. We've talked about it before. We've never implemented it, and there's like kind of technical reasons in there. Partly because we're always like looking at two groups, and if they both have that misclassification, they kind of cancel each other out. Partly because we've always looked at ways, like we know what the misclassification might be, and we have always looked at whether that level of misclassification for account for our findings. So we've done it in other ways, but that I think would be very interesting to do. Thank you.
So can I just point out that quote you talked about, if you can't measure it, you can't manage it. So it's currently attributed mostly to Peter Drucker, who's a management guru, who has made it popular, but it actually apparently originated with a statistician called Edward Deming, when he in fact said the opposite. He was talking about the challenge of measuring things that are hard to measure. And so what's ended up happening is that they popularized a section of what he said. So anyway, there you go. But Kieran Killian, though, for a long time has used a quote from Lord Kelvin, starting off with the same theme, really, that mostly says that if you want to understand it, measure it. And once you can measure it, you're off to a good start with respect to talking to people about it. So
That focus, if you can't measure something, your knowledge is of a meager and unsatisfactory.
that's exactly right. That's exactly right, Param. Yes, it's of a meager and unsatisfactory kind, your knowledge. Yes, yes. But I didn't want to belabor the point, okay? So
I love this fact checking. This is awesome.
well, I'm learning it from my kids, but no, but when you start off talking about quality of care in COPD, I sat there for a moment with a pen and paper, just wondering what would I think were indicators of quality. I had nothing like 33 options. So credit to you for coming up with 33. But you said something at the end that made me think that doing the spirometry is not enough.
It's
You
not
said
enough.
that. So what are Health Quality Ontario and Choosing Wisely, what are they bundling with spirometry to improve care? What are they going to get us to do? What's the package that goes with doing spirometry that moves the needle, improving quality of care?
Yeah, well, I mean, I think that the idea is that, so thank you for the question. I mean, when people put these things out, they kind of throw it out there and they don't really talk about what the next step is. But I think it's presumed that, once you have somebody with COPD and they've been diagnosed, then you go to the guidelines and you do give them guidelines-based care, which is measured by our other two COPD quality indicators. If they don't have COPD by spirometry, then why are they presenting with whatever they're presenting? And then you have to go back and do an echo, do a methylcholine challenge. You have to figure out what else is going on there that happens. So I don't think anybody believes that the pulmonary function tests actually make the difference, but it's what follows that. And I guess presumably people who get pulmonary function tests and are diagnosed with COPD, I guess your point is they're not getting the guideline-based care, but maybe if they were, they would do better, but not all of them, because some of them probably don't have COPD to begin with. It's an interesting thought, though. Thank you.
Well, it is interesting actually to know what would, I don't even know myself, what would I encourage to go with this, because telling somebody to follow the guidelines that's a bit of a, it's not a great start, because guidelines are very long and they don't apply to everybody, and patients have individual things. So anyway, it certainly makes us think. So are there any questions from outside? Can you, I can't see, where is that?
Oh, here, I can see.
Can you, thanks. There you go.
Okay. Some late bedtime reading, COPD Lancet Commission. Yes, thank you. Like I said, still making my way through. With all this data, why are we not moving to screening? Good point. Thanks for an insightful talk. So I think the screening, I think it's very interesting. Targeted screening. However you look at it, I feel like we are kind of heading in that direction, or at least, respiratory minded people are heading in that direction, but not other people. Thanks for an insightful talk. What is your opinion on doing away with the either FEV1, FVC lower limit normal and or less than 0.7, but rather the trajectory of FEV1 predicted over time? Would this be a better endpoint to pick up the fast decliners early before extraction criteria is met, particularly if they also have restriction due to obesity? I think that that's fascinating. I think that we should be having conversations about this. To find, I think we're about time, and that's why I like the Lancet Commission, but they're coming out. I think it's about time that we do look at what we're doing and start to reevaluate, and how do we pick up people. I mean, I think the argument would be like, once they're declining, maybe you've missed the boat on that. So we have to have better ways. But I like it that you're thinking about these things. And I think it's worth discussions. I don't know if you want to. I don't know if you want to unmute yourself. Do you have any thoughts, or I don't know if you're able to.
We've any other comments or questions from outside or in here? We are approaching 10 o'clock. We have had an opportunity.
Oh, sorry about that. My apologies.
Oh,
He says, I don't think I can unmute.
Yeah, we're having some technical issues this morning with microphones.
Oh, hello, I think I can unmute.
Oh, there you go.
Hi, thanks for unmuting me, whoever that was. Maybe it was Victoria. But the question was really related to understanding the trajectory of FEV1 over time and how somebody's lungs develop at the age of 20. And we know from some of the data that Alva Augusti New England Journal paper that some people have, well-developed lungs, some people develop poorly developed lungs, and then they can decline at different rates. So I often feel that by the time obstruction criteria is met, it's already too late, as you say. So that was, I wanted to get your opinion on what you thought on that.
Thank you. Thank you. But like I said, I think that new thinking is needed. We're still doing the same things that we're doing COPD like 30 years ago. So I think it makes sense to throw out these new ideas. Thank you.
Thank you. We've come to 10 o'clock. We'll close this round. We'll finish by thanking Andrea formally for coming and talking this morning and provoking many thoughts and revisions of our thoughts. So thank you very much, Andrea.
Thank you. So
We need to get back to
shall I can shut this down? Jerry, I can shut this down?
yeah, yes.